I would like to thank the team, organizing team of ESI, Professor Ganapati Pandwal, as well as the Nitin S. and Shaptarisi for giving this opportunity to share my views on arthritis in endocrine practice. I will take off 20 minutes of your valuable time. So I will put some 7-8 cases. So this is my overall view of what are the cases I am going to describe. So the first and foremost is hypothyroidism I am putting in coexisting with rheumatoid arthritis and obesity with the Cushing syndrome. And they may present with osteoarthritis or gouty arthritis. In diabetes, we may expect various forms of rheumatological manifestations, maybe a periarthritis, shoulder, Charcot's or tenosynovitis are now recently the drugs, even though some of the rare case reports are there. And at last, acromegaly and growth hormone therapy and hyperparathyroidisms. So basically, any inflammations of one or more joints leading to the pain and stiffness, and usually it will worsen with the age. There is the classical definition of arthritis. With this background, I'm moving to the case. This is a 28-year-old female, known case of autoimmune hypothyroidisms, on stable dose of thyroxine, 125 microgram, and currently the particular female is a euthyroidal with the thyroxine therapy. Otherwise, he completed family and cycles were regular, and anti-TPO antibodies were strongly positive. And with the stable thyroid disease, the particular individuals presented with joint pain, predominantly involving the small joints of both hands as well as the elbow and wrist. And she also had early morning stiffness. So there is a, whenever the middle-aged female presented with the classical polyarthritis and with the background of autoimmunity like hypoparathyroidisms, one should not miss the diagnosis of rheumatoid arthritis. So she was evaluated subsequently with the CRP. It was positive, even though the RA factor were negative. Subsequently, the anti-cyclic citrullinated peptide was done. It was showed positive. So the particular individual was diagnosed as autoimmune hypothyroidisms with rheumatoid arthritis. So just now back, Dr. Sachin were discussed about the polyglandular. This is fitting into the type 3D. That is a background of thyroid disease with autoimmune, the skeletal manifestations. So this is just a summary of whenever we have the suspicious of rheumatoid arthritis, the scoring system is there. So any score, this is American College of Rheumatology scoring systems. Any score more than 6, they are more fitting into the category of rheumatoid arthritis. So there are the clinical history like joint involvement is there. So 4 or more than 10 joints. And serology, though so some of the patients may be negative, but many of the times if you do the rheumatoid factors as well as the CCP, so both are complementary to each other. However, the anti-CCP is more specific comparing to the high sensitive rheumatoid factors because some of the cross-reactivity also may be there. So whenever there is a high CCP positive, the score is more than 3. So almost many of the times we may able to accurately diagnose the rheumatoid arthritis. CRP also again one of the markers and duration of symptoms. So anything more than 6, and subsequently we may treat or we may refer or we can use HCQ or methotrexate or any disease modifying agents or short course of steroids depend upon the clinical situations. And moving to the second case, this is a 56-year-old post-menopausal known case of bronchial asthma. And the patient was on chronic steroid therapy. And in India, it is a more common usage of over-the-counter abuse of drugs, maybe NSAID or maybe steroids across all over the India. And the patients presented with vomiting, loss of appetite, and poor oral intake. And she was admitted in emergency and with the bed bound. And she had also had severe bilateral knee pain and unable to walk. So one should not miss the diagnosis of Cushing syndrome. Probably this case may be exogenous Cushing syndromes like obesity or mooning of the faces, acanthosis nigricans, as well as the classical stria, and obesity and hypertension. And hypertension is again a little bit rare whenever patients presented with adrenal insufficiency features. And her cortisol was very low. And subsequently, she was evaluated with the X-ray knee. You can see that the narrowing of joint space, particularly the medial part, and the sclerosis of the bone at the medial compartment, that is the cortical thickening, and osteophytes or the bone formation. So these are all the features of osteoarthritis of any individuals with the high risk category. So this particular individual diagnosed as a exogenous Cushing's with a secondary adrenal insufficiency, with coexisting morbid obesity and post-menopausal age with osteoarthritis knee. So many of the times endocrinology may come across this type of comorbid conditions or multiple complications or multiple systemic involvement of the features. So one should not, so we have to manage as a holistic way instead of focusing as a hormonal part. So osteoarthritis, one of the most important risk factors is the muscle weakness or immobility, and the bone mineral density deficit, and the female gender, and the menopausal, post-menopausal age groups, and genetic susceptibility, and the coexisting calcium or vitamin D deficiency, and in addition to the obesity or previous injuries or activities. So there are a lot of comorbid conditions or the risk factors are involving in the causations of osteoarthritis. And predominantly we used to see only think about the osteoarthritis of the knee, but it can affect any joints, maybe the first carpometacarpophalangeal joints, and maybe a spine, or maybe a hip, or maybe the gout-like tarsophalangeal joint. So one should not forget about, think about all these osteoarthritic involvement in case of obesity individuals or the Cushing syndrome individuals. So we have to, whenever coexisting adrenal insufficiency, we have to use the steroids, and it should be tapered over a 3 to 6 months or maybe years, depend upon the abuse of the duration. And one should not forget about the management of calcium, and the vitamin D cholecalciferol may be a loading dose, and subsequently the maintenance dose may be a 60,000 units once monthly, or maybe 1,000 or 2,000 units per day. And one should know about physical activity, because it should be a muscle strengthening exercise. We should not cause disuse atrophy. So we have to encourage a lot of involvement of physiotherapists, or a lot of small physical activity. We have to in coordinations with the physiotherapists or orthopedicians, and appropriate management of bronchial asthma or osteoarthritis knee. There is no standardized treatment, so we can use it in a CAD, provided the renal functions were normal for a short period of time, or maybe intraarticular injections. Hope we have the discussions in the next thing, so we may discuss. And so far in the knowledge, there is the consensus regarding the usage of hyaluronic acids, and maybe intraarticular steroids for some point of time, but the hyaluronic acids is a chassis or this thing, there is no controversy, there is no consensus, and there may be a controversies. And moving to the case, this is a type 2 diabetes of 4 years on maximum oral drugs, anti-diabetic drugs with glimepiride, metformin.
Can we discuss in between?
So,
Dr. Is it the program that way? I don't know.
So I think next is the panel discussion, sir. This is actually...
Okay, fine.
If anything, we may come back again also, sir. After this, my talk is over, we will have the slides and other things. So this is moving to the case 3. These patients on maximum oral anti-diabetic drugs with a HbA1c of 10.2. And she presented with the pain over the shoulder area on passive as well as the active movement. And similarly, the pain over the wrist joint and aggravated on movement. So basically, it is a poorly controlled type 2 diabetes on periarthritis shoulder. So the recent terminology is frozen shoulder or adhesive capsulitis. And you can see that the causative area, the anatomical site is the glenohumeral joint. That is a pericapsular or glenohumeral joint capsule. That is a inflammations. So there is a restrictions of movements, as may be a arthritis or capsulitis. That may be the correct entity. And whenever any patients on the difficulty in moving or the features of carpal tunnel syndrome. So carpal tunnel syndrome one may encountered in hypothyroidism, or maybe in type 2 diabetes mellitus, or maybe in rheumatoid arthritis, or maybe in osteoarthritis also. So endocrinology may have the features of carpal tunnel syndrome. So this is the best simple bedside test, the Finkelstein maneuver, on grasping the patient's thumb and quickly abducting the thumb ulnarwards. The pain over the styloid tip is painful. So this is the maneuver. We can use it as a bedside. And moving to the fourth case, so this is a type 1 diabetic male and known diabetes for almost 13 years and basal bolus insulin with poorly controlled diabetes with non-proliferative diabetic retinopathy as well as the microalbuminuria. And this adolescent boy also had thickened skin over the palmar area and contractures of third and fourth fingers. So this is again one of the manifestations. In early stage, it may be a Dupuytren's disease, and later stage, it may be a Dupuytren's contractures. So you can see it depends upon the all based on the metabolic complications like the depositions, abnormal depositions of the advanced glycosylations end products. And in later stage, nowadays we are seeing rarely, and this is from the journal, you can see that diabetic cheroarthropathy, or there may be a limited joint mobility, otherwise known as a prayer sign or tabletop sign, unable to put all the fingers and over the tabletop, that is known as a tabletop sign. And all the pathogenic mechanisms are because of the metabolic complications and excessive, the advanced glycosylations in productive accumulations in the skin, tendons, and ligaments, leading to the various complications of the joint as well as the tendons or ligaments. So in diabetes individuals, the hand may be involved in multiple ways, as LJM or Dupuytren's or tenosynovitis or carpal tunnel or the arthritis. And this is various forms of exercises. And I'm not going into the details since the Professor Maheshwari is there, and we may expect in the next panel discussions all this form of therapy. And one should not forget about, or one should not forget to counsel regarding the various formulations of, because it's a muscle strengthening exercises, and we have to spend time for appropriate identifications of the diagnosis, then it will be more useful. And moving on to the case 5. So this is a type 2 diabetes of 15 years durations and premixed insulin for 8 years and presented with recurrent non-healing ulcers for 6 months and coexisting with a lot of loss of sensations as well as the food deformity. So any food deformity in a diabetic individuals and chronic non-healing ulcer or chronic recurrent ulcers with this type of the food deformity, everyone will diagnose as a Charcot's joint or Charcot's neuroarthropathic osteoarthropathy. In those days, 2 decades back, syphilis was the most common cause, or leprosy, but in recent days, diabetes is the most common cause of diabetic osteoarthropathy. And the close differential diagnosis is osteomyelitis, and we need MRI, or we may need a technetium scan or the bone scan to differentiate whether it is osteomyelitis or maybe in Charcot's we are dealing acute Charcot's. So basically the Charcot's is due to the abnormal autonomic nervous system and disturbances in the blood flow and leading to the bone loss. So the people may have the painless and loss of all reflexes and the bone fractures and injuries. And so this is the algorithmic approach. So X-ray in severe cases may be helpful to diagnose. In early stages or to differentiate osteomyelitis versus Charcot's, you need MRI or nuclear imaging. And depend upon the thing, the offloading is a compulsory one. And subsequently IV antibiotics or maybe use bisphosphonates for the acute Charcot arthritis. So in diabetes, there may be plenty of rheumatological manifestations. It may be the shoulder origin, it may be a hand origin, or it may be a foot, or it may be the spine. I am not discussed. So coming to the case, capsule 6, this is a 25-year female presented with recurrent pain, abdomen, and vomiting. And she is a known case of recurrent renal stone disease. And it was twice it was diagnosed and treated with stenting also. And subsequently, in view of recurrent renal stone disease, the patients were evaluated with biochemically with the calcium and phosphate profile. Still in general practitioners or physician side, the calcium profile is less often asked investigations. And many of the times we missed the early stage of primary hyperparathyroidism, and patients may present with a very late stage with a lot of pathological fractures or maybe renal injuries or hypercalcemic encephalopathy. So we can see that there is the bilateral the nephrocalcinosis, and the systemic scan, the delayed washout is showed left superior parathyroid adenoma. So the hyperparathyroidism is one of the important differential diagnoses of crystal associated arthropathies. So there may be a Lot of manifestations starting from arthritis to bursitis, tendinitis, enthesitis, and tophaceous deposits over the first tarso-metatarsal joint, and spondylitis or carpal tunnel syndrome again. So they depend upon the depositions or depend upon the underlying systemic involvement. The type of salt depositions may varies. Maybe a monosodium urate in gout, or calcium pyrophosphate dihydrate in maybe a hyperparathyroidisms, or again calcium appetite in a hyperpara, and calcium oxalate. So depend upon the metabolic conditions, there may be a various depositions in depend upon the severity of the stage of the disease. It can be deposited in various joints. And in our endocrine practice, we should not forget about primary hyperparathyroidisms, and similarly hypomagnesemia and chronic gout and Gentleman syndrome. So whenever patient is having hypomagnesemia, we should rule out the deposition disease. Many of the times patients may roam around here and there without proper diagnosis. So we should think about the clinical conditions and do the appropriate biochemical investigations. So this is one of the periarticular calcifications, maybe the localized joint involvement. So the simple X-ray. So this is another one is the tumoral calcinosis. Many of the times they don't have very systemic arthritis involvement. And moving on to the case capsule 7. So this is a known type 2 diabetes patients on initially metformin, then not tolerated, then subsequently switched over the clemipride, then developed a hypoglycemia, then again switched over to the DPP-4 inhibitors. After starting DPP-4 like sitagliptin, the particular individual developed a swelling and pain over the metacarpal, proximal, interphalangeal, and metatarsophalangeal joint. Then rheumatoid arthritis was made. And since there are some case reports regarding the gliptins and rheumatoid arthritis, the suspected it was gliptins-induced RA, then it was discontinued and started with insulin in coexisting with steroid therapy. So you can see that CRP may be one of the wonderful or best monitoring tool in case of DPP-4 related arthritis. And you can see that it can be in a late stages, it may be a knee arthritis also. And you can see after stopping the therapy with the sitagliptins and adding of steroids or hydroxychloroquine, you can see the tapering level of the CRP in these pictures. And so it was one of the studies. And there are a lot of studies, and in literatures also, there are a lot of immunomodulatory functions has been involved in DPP-4 related arthritis. But as already told by Dr. previous speaker, you can genetically predisposed individual like DRB3 HLA type individual, they may have increased risk of this type of adverse reactions. However, the benefits are more comparing with the less risk factors, and one should keep it in mind whenever patients, any patients on gliptins or any DPP-4 inhibitors developing arthritis, we may stop the therapy or we may add it some other oral diabetic agents. And this is the last case. So this is a 32-year-old the gentleman with progressive enlargement of hand and foot with increased chapel and ring size and coexisting weight gain with bilateral knee pain and increased sweating and a new onset of diabetes with recurring insulin. So the classical symptoms of acromegaly, and some of the features are suggestive of active acromegaly or the acromegaly in very severe category like the sweating hyperhidrosis, or maybe the coexisting severe arthritis. So this is one of the manifestations of severe acromegaly, and the worsening of diabetes control. That is again another features. So everyone will identify that this is some of the pictures I have collected. This is the classical of the coarsening of face and the acral enlargement. So one should not forget about the ones you see, but the recognition of acromegaly still is poor in the physician setup. So what are the mechanisms of acromegaly causing arthritis is the growth hormone and the IGF-1. The both stimulates the proliferations of cartilage as well as the periarticular connective tissues and bone, and leading to the joint involvement. And it can be manifested as a arthroarthritis, or maybe a back pain, or maybe a proximal myopathy, or maybe a carpal tunnel syndrome. So the acromegaly can manifest in multiple ways, depends upon the severity of the GH or IGF-1 involvement. Rarely in growth hormone therapy, whenever you are initiating as a full dose, they may cause arthralgia or arthritis, and moreover in coexisting hypothyroidisms or coexisting other obesity like factors, So we have to start with the low dose, or we may initiate this middle dose, and we can slowly escalate. So this is one of the rare cause of arthritis in endocrine practice. So coming to the summary, so the history taking is very important, and many of the times we may see the older individual. So the age is very important. Whenever in middle age group, the rheumatoid arthritis or other age is other rheumatological conditions are more common. Whereas in elderly age groups, maybe osteoarthritis or gout, or maybe osteoporosis, this is the more common reality. So the history taking and age and sex and coexisting conditions and drug abuse, these are all the factors we have to decide upon what arthritis we are dealing. So the history taking and clinical examination is very important to suspect arthritic involvement in endocrine patients. And the necessary biochemical and imaging modalities will confirm the diagnosis. And treatment of the underlying causes and precipitating factors will give the most of the solutions. And holistic management. So we have to approach a patient as a systemic way in all arthritic cases, and we have to counsel regarding the physical activity and muscle strengthening exercises and appropriate referral. So with that, I'm concluding. Thank you for your kind attention.